unfortunately, this area is assumed to get better all by itself. Most ladies are struggling with sleep. Most ladies are struggling with their new role, mental health, just balancing everything in particular.
How has it taken for me to be 37 years old to learn that?
That's probably why you're not good at performing.
So you're thinking, how are we going to get to that elusive G-spot? You can have sex, you can orgasm, doesn't mean you actually enjoyed or connected with your partner. Lubrication does not actually mean arousal.
Tell us, what is the problem with Kegels?
Everybody, make sure you poop.
Women do get it hard, don't they?
We can't compare.
Welcome back to the Best of Both Worlds podcast, the ultimate in healthcare conversations, where we look to discuss, consider, and potentially find the humour in our quest as healthcare practitioners to optimise performance. That is sports performance, sexual performance, emotional performance, and just performance in life in general. We hope to learn with you, to share with you, and to create powerful, high-performance lives. I'm Matt Winter, Doctor of Physical Therapy with training in functional medicine, and I'm here with Paul Macaulay, senior podiatrist, otherwise known on TikTok as the legendary Paul the Podiatrist. How you doing, Paul?
Yeah, I'm very well, very well. I think today's going to be a really fun episode. You know, we've been a bit of behind the scenes chat, and yeah, lots of laughter, so should be pretty good.
If we can keep it together.
Yeah, it's probably going to be my biggest struggle today. More importantly, we're both here with our special guest to talk about all things pelvic health and how the pelvic floor is key in sexual health in women. Rachel Tang, who are you? And why should people listen to you?
Morning, chaps. Thanks for getting me here today. I was so excited, and we're always excited to talk about sexual health and sexual performance. So just a little bit about me. So I'm a physiotherapist by training, and I have branched into the pelvis just a little bit more as a special interest. So for women, I think most people would think, okay, so why would I see a physiotherapist for my urinary issues? This is where the pelvic floor is key. The pelvic floor is pretty much the muscle and the thing that we control for everything on the in and the out. And we're thinking about things about your bladder, we're thinking about the vagina, we're thinking about the rectum. Anything with suspension, anything with the in or out, that's how we can control it. And that's where, as physiotherapists, we step in, right, Matt? Because we teach people how to move, we teach people how to manage their dysfunction. And I guess that answers your question of who I am.
Yeah, that's fantastic. To be honest, like being a podiatrist, didn't know a lot about the pelvic floor before I did research for this episode. So looking forward to learning a lot about it. And even when I asked my girlfriend about it, she knew nothing about it.
Yeah, and your girlfriend's a dancer.
Yeah, when you'd expect her to have some sort of understanding. So yeah, definitely after this episode, I'll be sending it to her. She'll be listening, not just listening to go to sleep, but hopefully listening to learn something today. So we've got a bit of a tradition here at the Best of Both World podcast, and it is to ask you how you are out of 10.
I do like this question because that starts us off with all performance, right? It's like mindfulness. Today, I'm pretty good. I would say 7, 8 out of 10.
Yeah. That's not bad. 7 or 8 is really quite strong.
And you were telling us off air that it's because you sent your kids to bed, you turned the aircon on for them, and you allowed yourself to have some free time and a good night's sleep.
If you have kids, you know that nighttime is not free time. In the night, you can put them to bed and they come back at you like at any times of the night. And I have 3. So you can imagine, you can one come in at 1 a.m., one at 3 a.m., and one at 5 a.m. The aircon keeps all 3 in the room. And that's like greatest tip in life, sleep.
We know that full well from the last episodes.
Yeah.
And if it's just about putting the aircon on, do it.
Yeah.
God, if I knew it was simple as that.
Full blast.
Doesn't even help with me. Brilliant. How are you out of 10, Paul?
Yeah, mate, I'm a 9 out of 10 today. I'm feeling great. Yesterday was awful. Felt awful. I didn't sleep well. But last night, one of my colleagues, Jen, shout out, gave me some lavender oil, which I, put on my temples, on the top lip. Yeah, honestly, slept so well. Got up this morning, did like an hour research on pelvic floor, and
Here you are.
here I am.
Hey, well done.
You're all primed.
That is impressive.
Yeah, so that was a good bounce back. And how about you, Matt? How are you out of 10?
I think I'm a 7 as well. I've been a bit fatigued. It doesn't help that when in Singapore people are very honest. And I got in the cab yesterday, and the taxi driver said, "Oh, I couldn't wake up, huh?"
Oh my God.
And and I was like, no, I could. And he said, "Well, your eyes are very smaller." And I just like, that's genetics. I said, let's talk to my parents.
He was probably
So-
trying to not say, your hair maybe needs a little comb.
But you probably, because you went for that look like 2 days ago, hair messier to make yourself look younger. So probably that was one consideration.
That is one consideration. Well, it didn't help my mood, so that brought me down a bit.
Yeah.
But no, I'm back up today. Good gym session this morning, ready to go, ready to rock and roll. I am very excited about today. So should we dig in?
Yeah, let's go.
Okay, let's talk about women. I think when it comes to the pelvic floor, this is the gender where people have a little bit more knowledge. I think, though, that it's largely built around pregnancy and recovery from pregnancy. So let's take it back a little bit. Let's take it back one step and talk about what's the full role of the pelvic floor in women, and why is it important?
Okay, so the full role of pelvic floor is a big mouthful. So pretty much we're looking at everything on the nether regions, everything on the bottom. Even we're talking about your bladder, your belly, underneath vagina and the rectum. Everything underneath there is voluntarily controlled by your pelvic floor. So in women, it is a very big deal in pregnancy as well as postpartum, just because it's like, for example, you sprained your ankle. You're going to think, okay, I'm going to need a little bit of rehab for that. I might be in a cast for a little while and I'm going to get back on my feet, get moving. But unfortunately, this area is assumed to get better all by itself. The tissues do get better. It's like one of the most vascular areas in the body. But when it comes to muscles, they don't get better by themselves unless you literally get conscious control of it, as well as you strengthen it just like any other muscle. So if you're thinking about pregnancy and postpartum, this is not the time that you have the time to hit the gym every single day. Most ladies are struggling with sleep. Most ladies are struggling with their new role, mental health, just balancing everything in particular. So usually this is not a part that gets very much attention. It has gotten better because, like for example, in France, every single lady that's gone through, they have found that it's actually more financially viable to get everybody pelvic floor therapy rather than to deal with the urinary issues, the surgeries that they have to face to stay continent when they're older. So that's just telling you from a systemic perspective how much this issue actually causes, bothersome nature. And this is just talking about urine. We're not talking about prolapse. So prolapse is basically when the organs do unfortunately descend through the channel and pop out of the body. It is bothersome for obvious reasons. Things that are on the inside should stay on the inside, and things on the outside should stay on the outside. When the organs do descend, it creates lots of tissue issues. It's uncomfortable. You feel heaviness. It obstructs your bladder and your bowel. And unlike your ankle, where you can strap up and use your other leg, you have no other choices with the bottom bits. Can you imagine if you have pain with urinating? How many times do you urinate a day?
Yeah, 5 or 6, I guess.
Yeah.
It's absolutely unavoidable. With an issue with urination, you might end up going like 10, 12, 14, 16. We've seen people that, have issues voiding. You're there, it doesn't come out, and you're just on the toilet all day. It's
so it
crazy.
massively affects your function.
Massive, massive. And it affects so much quality of life. And people don't talk about things like that. So that's just urinary function, prolapse, and now we're talking about constipation. Constipation is something I will bring up. A lot of people have no idea what constipation actually is. They're like, yeah, I go every week, maybe. And some people are happy with that. They don't even know what constipation is. The real sort of definition is rather wide. They're talking about if you have constipation, you've had an issue with defecating for up to about 3 months, more than once or twice a week.
I'm amazed because when I ask quite a lot of my patients about constipation. I ask it from a point of view of general health, right? So digestive health, as you know, correlates with a lot of other areas of health.
Absolutely.
And often they say, I go once every 2 days, once every 3 days. I don't know where that is going. I don't know how it's building up in there. I don't know why it's not coming out the other end.
Still within normal, but it's
Is
not
that within normal?
optimum.
So that's what I wanted to ask you. What is normal?
So
in
the
terms of
normal
frequency
is
for you?
once every 2 or 3 days, but it's not optimum. It's like saying you can eat once a day, but why are you, you're eating 3 times a day, but you're only pooping once a day? How the gut works is that it takes something in, there's peristalsis, and something else should come out. So we're so used to being, pardon the word, anally retentive that that you don't even feel it most of the time. And you can store stool. The rectum is meant to store stool, but you can imagine if you're storing stool for 2 or 3 days. It's not optimum. Yeah, if you're a person that eats a lot, lots of fiber, which a lot of people do nowadays, but they don't drink enough water, it becomes hard, it's difficult to get out. And can you imagine having to push a big poo out every 2 days? What's that going to do to an overstretch? Thinking about like if we say in terms of biceps, you're going to push your biceps to the limit of your 1 RM once every 2-3 days. What's that going to do to that muscle? So constipation, managing bowels, absolutely important for pelvic health, regardless of whether you're symptomatic or not.
And what do you think is optimal then? So we said, was it 2-3 times a day?
I would say optimal would be minimally once a day. Your stool, if you've seen the stool chart, would be nice and soft like a banana. You don't want pellets coming out. You don't want to be no straining. You don't want to have any sort of sensations while it's coming out. Obviously, no bleeding. Some people have had piles and hemorrhoids for ages. They'll tell me, nope, I'm not constipated. I go every day, but I bleed. What does that tell you?
And in terms of the other side of the scale, so high frequency, is that related to pelvic floor dysfunction as well?
It is, because if you think about high frequency, you're running to the toilet 4 to 6 times a day. Number one, you're not going to soil yourself every time you feel an urge. What are you going to do? You're going to hold it back. You're going to hold it that 5 to 10 minutes every single time before you go to the toilet. So then you're doing a strenuous holding exercise from the pelvic floor 4 to 6 times a day. Then you're releasing a stool that's really, really soft. And from the tissue perspective, that is very irritable. So you think about wiping and wiping and wiping. Even if you're washing, things on the inside should stay on the inside. If you're exposing that sort of the anal sphincter, external sphincter out too much, that is also irritable. So a lot of people do get tissue issues. Then you can't sit down, you have pain, and that drives an entire sort of like hypertonicity or tight pelvic floor, as we would say. So you could be absolutely like, I've had IBS all my life. There's nothing wrong with my poo. It's like, I really, really doubt that. You're putting yourself through a lot of strain.
Well, I went through actually a period of having what I would consider constipation, because it was like every 2 to 3 days. It didn't feel, and it was hard to get out. It's when I changed my diet a lot to try to lose weight, and I started to consume fiber, but I don't think I was drinking enough water to get it through the system. So it was just like piling up. And it was awful. Yeah, even Jesse gave me a massage to try and help me to relief.
Yeah, that's right. I remember that helped, didn't it? It piles up, and then you get piles on the out as well.
So no piles.
No piles. We don't want piles. Do you then counsel your patients as to nutrition that's going to help them? So we've already mentioned fiber. You mentioned water. A little segue here. What do you think is optimal in terms of water intake? And is there a specific time of day they should be taking that in more?
So to keep things really, really simple, if it's not broken, don't fix it. So if you already are pretty regular, you have no straining, stool comes out beautifully, type 4, you're off the toilet within 5 to 10 minutes, I would say you should be fine as you are. If you are symptomatic and you're like, when I poop, the whole world can feel it. It doesn't go down the toilet bowl, that's pretty hard. And that's when we do discuss a little bit, as Paul just mentioned, the balance, right? So if you've had a change in your diet, but you haven't had that extra change with the water intake. Some people, I do see this quite often with hard stool, where they go to the point where I'm omitting all fat from my diet. But fat is really, really important to keep stool soft. So if you think you're going to eat 3 apples that are really hard, they're going to come out that way as well, unless you have that emulsifier. So the other sort of tip that I would say, if you're really having hard stool, other than the water, you definitely want to kind of add a little bit of fat to coat. Whatever goes in, it's going to come out the same way. So I do counsel somewhat, but it's all based on symptoms and whether it's bothersome or whether it's optimum. So again, it's really individualized. And that's why I think there's no one fix all when it comes to performance and optimal health. You have to see where that person's at and what that balance is. Just one sort of comment with, hey, maybe you should take more water might end up with like 10 to 12 toilet visits, which then cause more problems than the stool issue.
And like dilution of electrolytes and all that kind of stuff.
And then they'll come in with cramps in their feet, and they're like, oh my God, I need new insoles because I'm cramping all night.
Well, I'll give them.
That's how you roll.
Yeah, exactly.
Okay, so let's just kind of summarize this a little bit. So the role of the pelvic floor is as a suspensionary
Suspension.
Tissues, right? and it involved in the regulation or the function of urination, of passing stool. It's involved in healthy
Organ
sexual intercourse,
suspension. Yes.
organ suspension. Is there a role for it in the musculoskeletal system in terms of transfer of weight through the pelvis as well?
Oh, absolutely. Thanks for reminding me. So, other than the organs being held up, it is actually one of the main postural stabilizers. So, this is where all sort of the women's health comes in, where a lot of people are very confused. They come in, I'm like all about my belly. I want to get my belly back, and I've got a little bit of leaking, pelvic floor, and the first thing that we kind of teach them is breathing. So breathing is actually it's a full system where, we've learned the previous podcast that the nasal passages, there are lots of diaphragms up there, 3 here and 2 down there. So breathing is the hack to kind of get both the belly, front abdomen, as well as our pelvic floor working. The pelvic floor is a stabilizer. If other stabilizers are not working as well, it comes in, it helps. So I always like to say it's like a little push and pull in a relationship with your girlfriend, boyfriend, or your partner, where if one is too strong, you're going to pull in a direction that someone's going to fall over eventually. Or someone's going to get tired and you're going to get a grumpy partner. So the pelvic floor is the partner to your back, to your abdomen, as well as your deep hips. So especially the external rotators and the extensors. So the pelvic floor is a big stabilizer. Plus it has all those other roles. So it's a pretty hard working muscle if you think about it.
Yeah, so all those patients we see with hip pathology, for example, microinstability in the hip, post-hip replacement, they all potentially have pelvic floor, maybe a little bit more prone to pelvic floor dysfunction, and I'm sure it feeds both ways. So
absolutely.
Is that right? Yeah.
Absolutely.
So we've got urinary control, rectal control, sexual performance, stabilization of the pelvis, and sort of involvement in breathing, and role in the hip and the musculoskeletal system.
Pretty
we
much.
Covered it?
Yeah.
Brilliant.
Perfect. So let's dive into its role in sex. What does the pelvic floor need to do in sex to allow for intercourse, and even more so, pleasurable intercourse?
Okay, so this is where we're talking about performance, right? So with performance, number one, we're going to assume that there's no dysfunction that causes pain. So we're talking about normal performance. So you're thinking, what's the pelvic floor to do? In women specifically, right, we don't think about the clitoris in terms of erection, right? However, the first role, if we're talking about sex, when you're having foreplay, when you're thinking about it, when you're hearing it, just the idea of that, having blood flow come in to get that clitoris erect would be the first role. If you are too tight, there's obviously not going to be very much blood flow. If there's not very much blood flow, then you're not going to have the nerves nice and primed. You're not going to be excited. No sex. So that would be number one, yeah? So if you're tight, that's a big issue.
I'd never thought about that. I never thought the pelvic floor can restrict blood flows to the clitoris. That is great.
So that's just, you haven't even started.
I wonder if stress affects it.
It must do.
Because then
Absolutely.
stress is like to do with the tendons, the stress in the tendons. And
in terms of
restricting blood flow,
adrenaline.
yeah.
That's an interesting point. So
Yeah.
we were talking about Achilles tendons, and there's some research that shows that when you're stressed, the adrenaline release actually changes the blood flow to the tendon sheath, so it restricts blood flow.
Affects the extensibility.
It affects the extensibility, and it affects the ability for it to heal and to take load. I would imagine there's probably a similar effect on the pelvic floor. It's just another muscle, right?
Absolutely. So you see this specifically in things like, for example, trauma. And they say that I have no libido, but the fact is that they are holding tension. They're afraid. The body is not able to let go. And you can't even get to that first step of arousal. And that's a physiological arousal. So that's covered the first bit. So we're just talking about clitoral stimulation. We're talking about a little bit of the internal erection and arousal. So secondary, let's say, okay, everything's working pretty well. Blood flow is good. We're on that time track, about 20 minutes, by the way, chaps. You guys don't need so much time. The women's clitoris needs a little bit more time because it actually is a little larger.
Sorry, 20 minutes of
Sort of
Foreplay.
foreplay. We're not talking about physical. It could be mental. You could be, taking out the garbage and things like that.
well, whatever works, right?
I don't know who or what the garbage is, but
I honestly wish it was that simple.
Yeah.
Yeah,
It
all
may
I have to
be,
do is
it may
take out the
be.
garbage. That is a win.
Okay, so
anyway, 20
taking out the garbage, the clitoris is nice and stimulated, arousal. Both parties are pretty happy there. And then we're talking about specifically vaginal intercourse. It can include anal intercourse as well. Slightly different set front and back muscles, but it has to be extensible enough. It has to have the range to accommodate whatever things that you're going to go in and out. So if your muscles are tight, you're going to have issues with going in. It's going to feel uncomfortable to one or both parties. Sex stops, pretty much. Who wants to have painful sex? What's the point? All right? And then on the pleasure side of things, right? So now that the clitoris is nice and erect, before it's erect, if you look about it, it's actually within the pubic rami. So you're thinking, hey, it's next to my bladder. How are we going to get to that elusive G-spot, right? So the clitoris, the larger it is, the easier it is to hit because it's a little bit of a stretch out. It's like a V shape. It's not that little nubbin right on the top. That nubbin is actually it's the tip of the iceberg, and it goes further in around the vaginal canal, which is why if they are aroused, then vaginal intercourse can feel pleasurable. But if you don't even get to that first bit where you're aroused, that's, sorry guys, looking somewhere in the dark.
So the clitoris is literally the tip of the iceberg.
It is the clitoris, the thing that you see is just pretty much it's like your penile tip.
Yeah, so the prominence of the clitoris is the tip of the iceberg.
Pretty
right?
much. But the actual body of the clitoris goes around and over the vagina. The vagina is a canal.
How has it taken for me to be 37 years old to learn that?
That's probably why you're not good at performing.
All right, mate.
That's why we're having the podcast.
Yeah, it's just all for Matt's learning. All for him.
Why do you think we've got you on? Very good. Okay, I'm learning already. So that's the pelvic floor and clitoral stimulation. But then there's a secondary role. There must be a secondary role.
So then, okay, let's say that everything's working, blood flows there, and everything's relaxed. You're getting into sort of penis-vagina intercourse. Right? Yeah. We're being very specific here. So penis-vagina intercourse. When you have that stimulation, the muscles are actually what cause that sort of strength or orgasm as well as that build up. They're the things that you can control to actually build up that strength and intensity of the orgasm. So it is actually pretty interesting. I was just reading that there was this research which correlated pelvic floor strength in women to how often they have sex. And surprise, surprise, those that have sex more often actually have stronger pelvic floors. They didn't know whether they went the other way around, but they also reported that sex is more pleasurable.
It could be bidirectional, right?
Exactly. So if you're having an sort of orgasm, it is a lot of contractions, strong, multiple contractions. That muscle would get stronger.
No wonder Pilates is getting so popular.
Yeah.
So, if it's helping with sexual performance.
Yeah, that's if you're doing it right.
If you're doing it right.
Yeah.
We'll
if you're doing it right.
We'll come on to that later.
Yeah.
I was just interested because I was looking at who has better sexual performance in women. And it seems there is some research suggesting that female athletes, and this goes along with the strength of the pelvic floor perhaps, have or they infer that they would have better sexual performance. But some of the research that's been done on this is about clitoral blood flow. And they show that female athletes have higher clitoral blood flow, and the inference is that therefore they will have higher sexual pleasure or performance. However, surely it's not as simple as blood flow to the clitoris.
No, absolutely not. I think the problem with research, as you know, is that research needs to be very strict for it to say, definitely this thing affects the other thing. However, with sexual performance, it's not that straightforward. So we've just talked about physiology here. We've just talked about the things that could structurally go wrong or go right. We haven't actually talked about the brain-body connection. So it is really, really tough, especially with women, to actually, I would say maybe always tick the boxes. And you guys probably know that better than I do, where you have to make sure that everything in the day has gone right, your mood is there. Physically, you have to feel within the body to actually even want to think about getting to that point of having sex. So it is a lot more complicated than actually that. So even things like time in your cycle can affect actually how you feel. And I'm talking about that clitoral blood flow. There are a lot of things that can stop sort of your sexual response system. So I would say that the other things that definitely would be things that you're talking about is their actual mental health, talking about their physical status. All those things can actually affect sexual performance. If you're talking about whether they can actually just go through with the act, that's absolutely something that can happen. But I think with sex performance is so multifactorial. You can have sex, you can have orgasm, doesn't mean you actually enjoyed or connected with your partner. So this is where this is a little bit out of my scope because I focus on the physical bit, but there is a lot about connection, there's a lot about communication that enhances sort of a sexual experience, which is then actually added into the sexual performance. So yeah, I think that does answer one area where probably if you're stronger, you do have better blood flow, you could probably get better orgasms and sensation, but it would be absolutely different with one partner to another.
Yeah, and also, there's conflicting research, right? Because female athletes also have a very high level of stress incontinence. When I first read this, it was 30% of young female athletes have stress incontinence, which is leaking, right? And then I read up to 50% in some groups, and then 80% have stress incontinence who are doing high impact or high intensity training. So now we're saying, yes, they've got higher clitoral blood flow, hence maybe more pleasure, but then they're also having higher levels of incontinence, which is linked to sexual dysfunction. So just isolating the clitoris is just small part of it.
It's
right?
a teeny tiny part of it. And as you said, right, these women are putting their body under a lot of strain. And I think nowadays we do see a lot more of that. Like there's so many of those weightlifters, CrossFit sort of videos where like, oh, this person's really strong and she's leaked all over the floor, right? So they obviously have maybe not a dysfunction when they're walking around, but they have a dysfunction in that particular task.
Okay, so yesterday I was talking to my male patient about how we're doing the episode on pelvic floor, and he was like, "Oh, isn't that all to do with like women weeing themselves?" And then he went on to talk about how his wife can't do trampolining anymore because she just said she can't do it. And so, what is it about physical activity that causes pelvic floor dysfunction, or what's the link?
Okay, so specifically with your male patient's wife, that's a little different because she's already had, assuming she's had a vaginal delivery, she's had a little bit of a injury or overstretch to that particular pelvic floor. So if you think about any other overstretch injuries, right, it's a new amount of movement that you have. It's a new amount of movement that you need to control. If you don't actually have pelvic floor control, which most people have no idea what the hell's going around down there, you're not going to be able to automatically, reflexively control. So I always say trampolining. If you can trampoline, you know that you have a decent amount of pelvic floor strength. We're not talking about like high impact gymnastics where you're smashing yourself into the ground. We're talking about just that up and down. So if you look at the pelvic floor, it is a hammock. And what it does is that it suspends sort of the bladder and the bladder neck. If you're going up and down, what happens is that there's that up and there's that sudden downward force. Your body is still going up, but your bladder and sort of that pelvic floor is going down. So you do need that suspension and extensibility that we were talking about before you actually have proper control. So keep it simple. If you have new range, you need to control that range, you need that strength, you need that speed, and trampolining is like all four wrapped into one bundle while being distracted that your kid's going to break something.
Is that like the sensation of like going up a hill and down a hill fast?
It's exactly that. So can you imagine?
That butterflies feeling.
It is butterflies every single time you jump on the trampoline for your bladder. So it is actually a very, very unpleasant experience because it comes with a lot of anxiety.
Yeah, I can imagine. Well, that's why the wife's just like,
No,
not doing it. You're on there. Unlucky. Good luck.
Fair enough. So like any other muscle then, when you're rehabilitating that pelvic floor, do you start with, say, strength or muscular endurance before we get to power and speed and that kind of thing? So what is the baseline? So what's like entry-level exercise for the pelvic floor? And is it about creating endurance in it first or strength? Where do we start?
you are almost there. The only thing I would need to add to that is that you need your range.
Of course.
So a lot of
Yeah.
people who are afraid of leaking, they are holding there all the time. There meaning they're like 3/4 the way up. They are never letting go because they're like, if I let go, I'm gonna pee myself. So they don't actually even have that range of movement. And a lot of the dysfunction we see nowadays is range of movement. So you can be shortened and tight. You can be lengthened and weak. But the combinations are endless.
Yeah, it's like hamstrings, and you can be short and weak,
Absolutely.
right? So I often explain it to, hopefully I'm doing this right when I explain this, because this is not my specialist area. But what I say to women is like, if I ask you to walk around with a coffee mug all day, just holding that light weight, at some point at 6 o'clock when someone just taps your arm, you're going to drop the mug.
That's exactly it.
And it's the same thing with that clenching, right, of the
Yeah.
pelvic floor all day.
Absolutely. So
Yeah.
you're just tired at the end of the day. And some people are just really, really strong. But at that certain point in time, maybe it was a bad combination. You can let go and you can leak. So with ladies that are really, really strong, you do more strengthening. That actually worsens the fatigue. And a lot of those that end up doing that will also tell you that, hey, I started doing Kegels and I got a lot worse. I couldn't even pee.
So tell us, what is the problem with Kegels?
So the problem with Kegels is that you don't actually do exactly what you discussed. We were talking about the range, you're talking about endurance, you're talking about the strength, the coordination, the timing. So it does not include all of these different factors. It's literally throwing squats to every single person that has knee pain. And we know that's not going to work. That's going to work for some people. And for some people, it's going to absolutely put them in a series of inflammation.
And it's how you do the squat, in what position, for how long, how deep, right?
It's exactly that.
I heard from another pelvic physio that I worked with before that the other problem with these exercises is that often people are bearing down or pushing down rather than drawing up. Can you explain this concept of lifting the pelvic floor versus bearing down?
Okay, so we have to go back to kind of that trampoline or hammock. So you're thinking that you've got two different levers or the table on each side. That muscle in between is a little bit of a bowl. So the problem with this muscle that other muscles don't face is that you can't actually see what you're doing unless you're a little scooped over with a mirror looking at your bottom. Bearing down is when you're going the opposite direction of what you're supposed to be doing, which is lifting. So let's all just practice this right now. We're all sitting down. You're going to scoot and see whether you're on your sit bones. Everybody at home listening, same thing. So feet apart, feet on the floor, and you're going to say, am I sitting somewhere in the middle of my sit bones? Feels pretty okay. So if you're male, you're going to lean forward. You're going to go, okay, my testicles can reach the front. For females, you're going to feel it a little bit more around your labia. You're going to roll all the way back into your tailbone. We don't want to be on either end. So you want to be somewhere in the middle. Okay? So you want to make sure right here that you're somewhere in the middle. If you cannot feel anything on your bottom, you are absolutely tensioning. You may not be tight, but you're tensioning away. Can you relax your anus? You're not going to pee as long as your bladder's not full. And then you're going to relax all the way down. So now we're somewhere in the middle. Bearing down is if we're going to go, I'm going to blow up my belly. I'm going to push down. I'm going to think about being a rocket flying towards the ceiling. You're going to push down with your anus. That's bearing down. And you can see with a movement like that, if your bladder is full and you're thinking that that's a pelvic floor movement, you're just going to push out more pee. So it is absolutely the opposite. And we see this actually mostly, again, in bowels. So a lot of people think that, hey, I need to push poo out. I need to push pee out. But as you do that, you actually tension your sphincters. And it's like saying, I'm going to walk out that door, but I'm going to close it really tight.
Is it the same with orgasm?
It is a little bit similar in that sense. So we're assuming everything else has been done right for the brain, physiology, and you're connected. So with orgasm, if you are not relaxing, maybe for women not so much, but for men with premature ejaculation, you do actually find that issue where they're tensing so much that you actually go into a hypoxic state and then they lose control. So breathing is actually one of the best ways to control the speed of orgasm. Because you relax the muscles, you relax the body, and you pace yourself up rather than going for like a speed run.
If we come back to like the incontinence and the prolapse stuff, I've seen these clinics where they offer like treatment. They're not physios. They're just offering these like SIS machines. Like
We all know who they are, but we shall not name them.
Yeah, those yeah, exactly. I was told that I couldn't name them by Matt, but
They're all on the
legal
bus.
team advised.
Yeah, our legal team.
Yeah.
Of Matt's mate, Adam. So are those machines doing anything?
To be very objective, the machines do what they say, which is they give you many small contractions. So they do actually work for a subset of ladies who literally just have weakness in the superficial pelvic floor. So these ladies that are weak have no extensibility issues. It does help to a certain extent, but it's the same as any exercise. Can you think about it? How strong can your biceps and your quads be if you're doing 10,000 bicep curls? It will never be as strong as if you loaded it up with your 20, 30 kilos.
Yeah.
And then there is a subgroup that will get worse with it.
There is a subgroup that get worse. Luckily, though, I find that in the Singapore settings that they don't necessarily get worse with their urinary symptoms, but they get worse with other issues with sort of insertional issues, and we're talking things like speculum, tampon usage, menstrual cups, along with vaginal intercourse. Because it's just gotten to the point that it's so tight, it's non-extensible, it's never stretched, and then you can create that sort of side effect as well.
Yeah. So should people be avoiding these places and seeing a physio instead?
I will not say that directly, because they do benefit certain types of people who aren't very active. It's enough for them, and I would say that that's what they can manage on a consistent basis, to go in for a zap every 6 months.
Yeah.
However, if you do find that there are limits to it, please do get checked by a medical provider. The people that I would say should avoid places like this are actually those with really severe and constant issues, because they usually have a structural issue. And for those that are in the field, we know what are red flags, who needs to go and see the doctor. I would say that these people are not trained to pick out structural issues or red flags that would definitely need to be reviewed by a medical provider. So that's where I put the caveat is, if it's really severe onset, all of a sudden, go and see a medical provider first. If it's been a long time coming, maybe a little less, it's getting worse a little bit, you probably have something severe going on. Also better to see a healthcare provider first, and then maybe you can try that out.
Yeah. Well, we know that our main role, which we often discuss, is to pick up those red flags. Like, that's the most important thing in our job, is that the day-to-day plantar fasciitis is fine, but when you see those like inflammatory conditions where you're just seeing it, like we did yesterday, both of us, that we are like, we need to be picking those up, and that's where you get it with the medical professionals, hopefully.
Yeah, absolutely. And if they're not trained, they won't know what's normal and what's not.
Yeah. So, what are some concepts that women can take into their exercise and even daily habits to start to work with these issues?
Okay, thank you for asking. It's going to be a soapbox, but number one, everybody make sure you poo. Don't hold your poo. Because if you're thinking about it, you're holding your poo all day, what's your pelvic floor doing? Making sure you don't poop yourself. Don't hold your pee. If you can't, hold it for a little while. Go to the next chance. So you don't want extra tension and taking away from its stability and support role. So that's the first thing I would say with exercise. You do want to make sure that muscle is actually able to do what you're going to actually train it to do. So pee and poo out of the way. Make sure that's nice and regular. No pain is allowed with things like that. For exercise, if you know how to activate your pelvic floor, you've done that little check, you're sitting, I'm not bearing down, I'm lifting when I have to, I can stop my urine flow, I can stop my poo if I need to. You've got a decent amount of strength. This is when you would want to coordinate with any exercises that require the lower quadrant. That includes all your core work. It could be your planks, it could be your crunches. Make sure you're breathing through it. If you're doing glutes, I love glutes and pelvic floor. They work together. So if you're doing bridges and squats, you just want to think about, hey, what is my pelvic floor doing? Am I pushing down? Am I pulling up? If you're doing the contractions at the same time, perfect. You're actually looking after your pelvic floor. It is not necessary for you to literally do 100 pelvic floor contractions every single day. In life, We breathe. If we breathe, that pelvic floor is moving, it's beautiful. I would say that you've got good range. If you're lifting weights, you're squatting, going through your full range of movement, you're strengthening your pelvic floor. So the takeaways are figure out what you're doing. It's as easy as looking into the mirror, having a little finger underneath the tailbone. It can be within the vagina if you're comfortable. Are you squeezing when you're squeezing? Are you letting go at the end of the contraction? Utilize your current exercise regime. It doesn't matter what you're doing. If you're a yogi, you're in a deep squat, make sure you've got a little breathing going, squeeze and lift. If you do Pilates, make sure you relax at the end of your teasers. If you're doing weights and squats, hey, if you're not leaking, your pelvic floor is working. Okay, so the summary is make sure you know what you're doing, stretch your hips, stretch your pelvic floor, breathe through your belly, load up with a little bit of weights, a little bit of tension. Whatever is consistent, that is what is going to get you your best pelvic floor outcomes.
Amazing. And make sure you're peeing and pooing and not holding.
Pretty much. We're so used to holding here.
Great. I'm so pleased that you mentioned letting go. One of my pet peeves, and we'll come on to pet peeves later, is people saying I'm trying to activate my glutes. And I feel like because of this glute obsession that we have, that people are walking around trying to activate their glutes all the time. And I think that's crazy because it's phasic. It should turn on and it should turn off. Do you find a problem with people now trying to hold their pelvic floor all the time during exercise? So, and what cues do you give women during exercise to make sure that that's on and off, if that's the case?
I absolutely agree with you. I actually see a lot of bladder dysfunction because people are told you need to have good posture. Everybody's sucking your belly. And these people never let go, and they're in these really tight tights, and they're holding it in all day. And they're like, Rachel, why am I leaking sometimes and why do I have back pain? All I tell them to do is breathe and lose her pants, and they get better. Nothing else.
How do they feel about being chubbier then? Like, because they're holding in, aren't they? So, like, then you tell them to release, and then they're walking around like this.
But basically, we're just telling you to hold it in when you need to, but let it go when you don't. So these people have been trained to think that I need to squeeze everything all the time. But if you never give yourself a break, it's the same with any other part of life, right? We need to be able to have little breaks, and then we'll get stronger. So I absolutely agree with you that the cue for me is pretty much when you're not doing a particular exercise or you need it on, don't actually think about it switching on. It's the same with the glutes. It's the same with the pelvic floor. So one of the things that we see a lot in the postpartum population is like, okay, everybody work your glutes. And then they never let go of their glutes. And you're like, look at that. It can never let go. They bend forward. And they're like, oh my God, my back. All you need them to do is, hey, come on, let's get you to relax. Touch your toes. You don't have to think about switching on your glutes. If you're not falling over, you've got your glutes switched on.
So it is. I mean, and you can see, Rachel and I sometimes sort of joke about this a little bit because
staring at people's asses all day.
Well, it's like
Don't
me
say that
staring
on
at people's
camera.
feet. I've just clocked that Rachel's wearing Skechers, and
God.
honestly, could have picked a worse shoe for me to see today.
Now that's all you're thinking
I
about for
can't,
the next 20 minutes.
Yeah. Well, I spent 20 minutes thinking about your husband. Now I'm just going to spend the next 20 minutes thinking about how disgraceful those shoes
What
are.
have you been thinking about, husband?
We'll get onto it later when we
Stitch you
talk
up.
about men.
Podcast will be
Once an
fun.
episode. And now I'm looking around looking at people's jaws and are they mouth breathing after the last episode. It's horrendous. I can't walk anymore. I can't go out of the house. What are we talking about?
We're talking about glutes.
Oh yeah, there's
Booties.
when people come in, and now I can almost look at them and be like, I bet you've got a hyperactive pelvic floor, you clench your teeth, you've got anxiety, and almost how they sit on the chair, like really upright on the edge of their
Or
chair,
like there.
and they're like, they're stressed, and when I refer to Rachel, I'm think they have these group of symptoms or group of this constellation of problems. Do you see that all links together? So my personal opinion is pelvic floor dysfunction seems to go with TMJ or grinding. And breathing dysfunction and lower back pain and chronic pain in general. Is that something that you see in your practice as well?
I absolutely agree with you that they do tend to come in sort of a constellation. I think it goes back to very basic anatomy. If you're thinking about all the muscles, our jaw and our pelvic floor, they're the only muscles that actually kind of control an orifice where things go in and out. They are also muscles that lie in a slightly different plane. They work horizontal versus everything else, which works vertical. So the same stresses that would stress out your pelvic floor would also stress out your TMJ.
And your diaphragm. And
Absolutely.
your thoracic outlet.
Exactly.
All
So
those horizontal.
they all are affected by the same thing. So then that goes back to like breathing and pursed lip breathing or nasal breathing. You've got issues with that. What's going to happen? That's going to throw off that intra-abdominal pressure. You're going to put pressure somewhere else. And then after that, usually the pelvic floor is not the primary unless you have had a specific injury, like a vaginal birth, or you've fallen on it, or you've had a surgery in that area. A lot of times it's just kind of the loudest sort of wheel in the cog.
It's a great way of explaining it. You've mentioned vaginal births a few times as a stimulus for pelvic floor dysfunction. What about just carrying a baby in itself? So women that have had C-sections, but they've carried a baby for 9 months. Is that enough as well to give pelvic floor dysfunction?
That's absolutely enough. So some ladies are really surprised. They're like, hey, why do I have sort of intercourse pain after I've had a C-section? I didn't do anything. And then you look at it. They're like, hey, actually they did an induction. It was a failed induction. They were actually contracting for a long period of time. There was a lot of stress and strain around that area on top of the pregnancy. So one of the biggest factors to tell whether a person will leak post is actually whether they leaked pre. And these are nulliparous. They've not had any children before. So if you had leaked pre, we know you have those factors. You might be too tight, you might be a little weak, or you're very stretchy. If you're very stretchy, what happens is that you go past a certain length. If you're those that unfortunately have sort of a standing job, that muscle never has time to rest. It lengthens. It is not able to go back to its previous length. And that's what we see in a lot of things like patellar dislocations. You know, there's a certain point that they can manage, and at a certain point it's just over the top. So that's where those in pregnancy can have those issues because of that weight as well as the stresses that have gone through. So one of the questions we do ask is that whether you had really bad morning sickness. Because then can you think about having a baby in the third trimester and puking all day long? How much stress and strain do you have on that pelvic floor? And you have not even given birth yet.
Oh, God. Women do get it hard, don't they?
You guys really, definitely.
Yeah,
Wow.
we can't compare.
Go back and thank your partners.
can't.
Absolutely.
Well, yeah, we'll when time comes.
Oh, God. That's just like
Are you
thought.
crying?
No, just the thought of all of that going on at the same time is stressful.
Man.
You're a sensitive
No,
guy.
but that's a lot to go through.
Oh, so sweet of you.
No, he is. That's why he's got women queuing out the door.
Yeah. Anyway, right.
That's been that way for a long time.
No, it's not for dating. I mean, it's just for like
just so I listen to.
He's not the one with the free coffee, though.
yeah.
Yeah, that's true. Yeah.
There's something about
So,
that.
so you mentioned patients that are a little bit more stretchy than the average. Are we talking about the hypermobile population here, who we see a lot of, right? You see it for feet, and I see it for a lot of different joints. Should we be almost screening these patients or preparing these patients if they are thinking about getting pregnant, that they might need to see someone like yourself in preparation?
There isn't a lot of evidence in prevention, but there is a lot of sort of data to say that these particular subset of patients that have extensibility issues, they do suffer more from these sort of issues like prolapse. So it would be advisable just to see where they're at, maybe during the pregnancy. We do measurements actually for what we call is the GH plus BB, where we can kind of tell whether this person would have a higher likelihood of having a prolapse. These patients are also the ones that we would be thinking about a specific exercise program or things that maybe they shouldn't be doing during the pregnancy to prevent these sort of disorders. This is really specifically for this subset of patients. Majority of pregnant ladies are actually advised to do the opposite nowadays. I think you guys are aware that, especially in the local population, everybody's freaking out once they're pregnant. It's like, okay, sit down, But they should be exercising more, they should be exercising the same amount, and that would be protective of pelvic floor. Only the subset that is very extensible or super constipated and things like that have those certain sort of predisposing factors would be the ones that we would say, hey, maybe you should really take it down a notch, wear certain sort of supportive devices throughout the pregnancy to support you all the way through and prevent that overstretch happening before even the labor.
And so with those people, do you do, like we do, like the Baton scale of hypermobility? Do you have like a certain scale that you use? That you mentioned something.
Yeah, so we do the Baton scale as well, because that's part and parcel of it, especially for the abdomen. We also do, as I mentioned, the GH plus PB is where we actually measure the genital hiatus.
Okay, what does that mean?
So basically, what you're looking at how wide that vagina is from the top of sort of the bladder to the bottom. This is an important one also because it does kind of correlate to how bad a person can tear. Yeah, because if you are narrower, a lot of times they have more problems with kind of getting the baby out because the baby's size of the head doesn't change, but sort of, that space needs to change. So it goes both ways, where if we know that it's really wide, they do have certain predisposing factors that we have to educate them about. If it is a little bit more narrow, that's the people that we would say, maybe you should start doing some labor prep where you're going to learn how to relax that area, you're going to stretch out that area before the baby is going to come out. And that usually comes about 36, 37 weeks.
Okay. Do you have a device that measures that, or is it like ruler?
It's called a pop stick.
Oh, okay. All right. Nice.
It doesn't go in. It stays on the outside.
That's good. That's good. Right.
Welcome to women, man.
Yeah, well, it's not like we only go to like, well.
It's a pity this is a podcast. Everyone should look at your faces right now.
No. Well, if they're, well, hopefully they're watching on YouTube, and then they can see it. Maybe just switch across to YouTube now just to see it.
See your face.
Yeah, see my face. How red it is. It's not normally this red.
I'm normally the redder one.
Yeah.
We haven't even talked about periods yet.
Oh, actually, we haven't got any questions about that.
Thank goodness.
Yeah.
No, but I know about periods because my girlfriend has them.
Well, you must be an expert.
Oh, I am.
Yeah. So 40 to 45% of the female population will have urinary or female sexual dysfunction in their lifetime. I would imagine one of the main causes of that is pain during intercourse, in terms of the female sexual dysfunction. What are some causes of pain in intercourse?
So this is not really spoken out loud, but there are really, really a lot of reasons why a person would have pain with insertional intercourse. So the first one would be the most obvious, actually, is that you've got an infection to the area. The reason I'm bringing this up is because it usually starts something small, but people ignore it. They're like, yeah, it'll go away. But if you think about an infection to any other part, like the foot, the tissue is a little bit more friable. It's not as healthy as it used to be. It takes a little bit of conditioning. So what happens if, let's say, someone has a thrush infection, the vulvar tissues are a little, just a little frail, or they're breastfeeding and their estrogen is low. That tissue is actually very, very sensitive, and it does tear easily. Unfortunately, with insertion and intercourse, it is something that's repetitive. There is a lot of friction. So with issues like that, if you had an infection, you don't deal with it, you will eventually end up with a reflexive response. You're not going to allow anything in, and the pelvic floor is the gatekeeper. So in cases like that, where you have an infection that drives that sort of tension, if you don't know what's going on, every single time you're going to have sort of that reaction or that put in that situation, your pelvic floor will tense. So then the pelvic floor becomes the bad guy, because the pelvic floor is the one that's protecting you. So the pelvic floor actually does cause pain because it causes tension, it closes up the orifice, and then after that, things just don't happen. So that is one of the reasons where you can have pain, which you just have an infection. And after that, that creates a fear response, a trauma response, and then the pelvic floor does become painful. Other instances where it can become painful is like, for example, if we're talking about primary, they've never had things go in and out. So this is feared, which is the hymen, right? Everybody's like freaked out the first time I have sex, I'm going to bleed all over the sheets. So majority of the time that is not the case, but some ladies do have different hymens that do cover and can cause issues. So in cases like that, the painful sex is because you literally have that tissue blocking that vagina and you're having a stretch in an area which is it's not quite very comfortable to have. Sex, penile vaginal sex, is repetitive and that stretch can be painful. And then here comes our big brother, the pelvic floor, which is protecting you again. Again, it can cause pain. So I think these two are one of the very obvious ones where people can actually have pain with sex. Other things would be sort of hormonal changes within the cycle. Same thing where it affects the tissue sort of friability, maybe not so comfortable, less lubrication. It can be painful. It creates a pain and fear response. And then after that, it just continues until someone kind of explains to you or you figure out what works and what doesn't.
So to summarize, the pelvic floor can be both a primary driver of pain and it can be a secondary driver, so responsive to other things going on.
Absolutely.
Brilliant, thank you. You mentioned lubrication, and we also spoke about hormones. I would imagine they're very interlinked. Is there a good time in the cycle where women are more lubricated that we can consider when having sex?
Okay, so this is a physiological response, and the simple one is the body is so clever, right? You want to have sex when it is the best time to actually reproduce. That's the whole point from a physiological perspective. So the part of the cycle where women tend to be a little bit more lubricated is pretty much the pre and during ovulation. I do have to put a little disclaimer though. Lubrication does not actually mean arousal. It can come with arousal, but it doesn't actually mean that they are aroused. And that's an interesting thing to note, guys, because if you're going to feel around, don't think that, wow, she's really wet. She must be
so wet for
really
me.
aroused. It might just be the time of the cycle.
But if she is more lubricated, I would imagine the intercourse would be more pleasurable or less painful, and it could lead to greater arousal.
Correct. So then with the lubrication, there are a little bit more options that then you could definitely do, especially in terms of duration, because then it would be less taxing on the tissues.
Conversely then, if a woman is not lubricated, does that mean that she's not aroused, or can they be aroused and not lubricated?
You can exactly have the same thing there. It's like it can be the opposite direction as well. And that's where hormones again come into play. They can be aroused. The clitoris can be erect, as you can see. However, because of that cycle, the time of month, there is a little less sort of internal lubrication. And that's where the partner's sperm comes in, seminal fluids, then that makes sex a more manageable sort of recreational activity. Places in the period that generally are less lubricated, that need a little bit more help, external help like having extra lube on hand, would be when progesterone is high. And we're talking just after ovulation, before the period. But that generally is easy to tell because most ladies are not in the mood. Progesterone brings a lot of different things like bloating. It does create a little bit more pain, cramps. That does actually spoil the mood somewhat, and it is more difficult. Doesn't mean you can't, but more difficult during that period of that cycle to be aroused.
So clitoral engorgement would be a better indication of arousal than lubrication.
Absolutely.
Cool. Good to know.
Nice.
We've spoken about pain during intercourse. We've spoken about incontinence and exercise. What we haven't spoken about is this group of women that encounter pain ongoingly. I guess that could be termed a chronic pelvic pain, and we can call that a syndrome. Apparently 1 in 7 women experience this, and 50% of this group, it goes undiagnosed. I want to read you a quote from the National Institute of Health about the management of this that shocked me. Some patients with chronic pelvic pain benefit from cognitive behavioral therapy and hormone replacement. In contrast, others may require more invasive treatment interventions such as spinal cord stimulation or a total hysterectomy. Surely there's a role of physiotherapy here.
Yeah, this is definitely a place of I would say it's a gray zone where research is way behind clinical practice and what people have found. I'm going to counter you a little bit with just one of the conditions that actually cause chronic pelvic pain. So endometriosis. Are you familiar with that?
Yeah.
So endometriosis in general takes 10 years for people to diagnose. And endometriosis is where, for those that are not familiar with this syndrome, the endometrial, so the uterine tissues, unfortunately are growing other places in the body. So just like, if organs are supposed to stay in a certain place, your endometrial tissues, by right, should stay in in your uterus, yeah? These tissues, unfortunately, go through the same cycle. So can you imagine you've got this lump of tissue that is on your intestines and it's growing and it comes back down and it bleeds into the abdominal cavity because it doesn't come out through the vagina, right? So it would obviously cause structural damage and pain. But because these ladies are having it during the cycle, a lot of them are waved off, take a pons done, go home, sleep. And the longer this goes on, they have more and more scarring, which then leads to what we call the adenomyosis. They come together because if you've been bleeding and then that's structurally been going on all the while, these things cause somatic pain. Okay, and then they end up with chronic pelvic pain, and there's we go back to your old podcast, which was the pain podcast, where you've got something structurally wrong and it's going on and on and on, your body gets sensitized to it. It's clever, right? It's not going to put itself through that again. You reduce how much you move, and it creates that giant cycle of fear avoidance, as well as the fact that people don't believe because they don't have a diagnosis. So just that one syndrome, already 10 years, can you imagine how much sort of agony this person is in? And that's on a daily basis. We're not even talking about sex. We're just talking about function. So it is unfortunately not well managed because it is absolutely underdiagnosed. And then after that, pelvic physiotherapy's role here, just like in any other pain conditions, is to manage what you can change, what is modifiable, as well as to boost your immune factors or that physical syndrome. We have seen patients like endometriosis patients specifically where their pain does come on. We can't do very much about the pain within sort of that cyclical behavior, but all the reactions that come around it compound that pain. That's where physiotherapy can help and make a very big difference. So with all these conditions, it is not so straightforward as to say, hey, you think it off, your pain, because there's no particular reason for it. But there are a lot of physical things that start, just like what we were talking about with the reflexive sort of genital pain on penetration, where there's a reason for it. It was ignored or not discovered, and then it creates that cycle. So people say, hey, it's the pelvic floor's fault, but the pelvic floor is a responder. And you have to untrain that, but you still have to figure out what the main diagnosis was, work with a medical practitioner to kind of manage that better, and then we can deal with sort of the reactions after. So there's absolutely a role for physiotherapy. You don't even have to be like a pelvic floor therapist. You just have to have a good wrap around what the red flag is, certain patterns, and if you can direct it to the right person or practitioner, they will get the help that they need.
So I ask, is your pain cyclical? So all my lower back pain, hip pain patients, even like abdominal, I say, like, is there a cycle to it? So does it come on for 2 weeks and it goes for 2 weeks? What are other signs that people listening can listen out for if they're concerned that endometriosis might be a driver for their pain?
So that is actually the main one, and that's a good point out, where if there's a cycle of behavior, definitely you're talking about endometriosis or things that are related to sort of the gynecological spectrum. If we're talking about pelvic floor or things conservative can help, the simple thing is, do you have any issues that wax and wane? So for example, do you only certain times of the month or certain times of the day you're unable to pee, you're unable to poo, or you find incomplete? If you have anything, pee, poo, or sort of, what's that word again? No, not intercourse, but anything with the ins and outs of the vagina, having difficulties, I would say that the pelvic floor is probably there at play. You may not have a structural thing. That's why when they check you, there's nothing wrong with you, but it waxes and wanes depending on what you do and depending on the cycle. So if you have a condition that sometimes is there and is sometimes not, very likely the pelvic floor is there to at play because it is a responder.
Wow, I've learned a lot.
Yeah, me too. I knew nothing, to be honest, before I researched a bit.
Yeah.
And now I know, hopefully, a lot more.
But at least, again, we can, in this healthcare realm, the more of us that have some knowledge and we can start to screen and pick things out, at the very least, as Rachel said, we can direct our patients to the right people.
Yeah.
Which is fantastic. Rachel, it's been incredibly interesting. You're going to stick around and do another episode with us when we talk about men.
I hope so.
And then we will ask you your pet peeves and your magic wand segment.
Not like that.
Until then,
I should have brought the magic wand.
You should. I'm sure you've got a few magic wands in your cupboard, haven't you? We will talk about the wand later, maybe. Rachel, thank you so much. We've had a great time and learned a lot. I hope you've enjoyed listening as well. We will see you for our next episode. Until then, take a deep breath, relax that pelvic floor, and we'll see you very soon. Take care.
Goodbye.